Welcome to this video entitled, Nosocomial Pneumonia. We will begin with a few definitions. Nosocomial pneumonia is an infection of the pulmonary parenchyma caused by pathogens present in hospital settings. Nosocomial pneumonia develops in patients admitted to the hospital for more than 48 hours, and the incubation period is usually no longer than 2 days. Among nosocomial pneumonias, ventilator-associated pneumonia, abbreviated as VAP, which will be the main focus of this chapter, develops in intensive care unit patients who have been mechanically ventilated for at least 48 hours. In contrast, ventilator-associated tracheobronchitis, abbreviated as VAT, is characterized by signs of respiratory infection, without new radiologic infiltrates. Healthcare-associated pneumonia, abbreviated as HCAP, develops in patients who are not hospitalized, but have risks for being colonized by nosocomial multidrug-resistant, abbreviated as MDR, pathogens. Risk factors for developing healthcare-associated pneumonia are hospitalization for 2 days or more within the preceding 90 days, residence in a nursing home or extended care facility, home infusion therapy, chronic dialysis, home wound care, and contact with subjects colonized by multi-drug-resistant pathogens. Several North American studies have reported that multi-drug-resistant microorganisms primarily cause healthcare-associated pneumonia. Conversely, European data show greater similarity in microbiology with community-acquired pneumonia. Nosocomial pneumonia is classified based on the presence of microorganisms isolated from respiratory surveillance cultures and includes the following categories. 1. Primary endogenous pneumonia, in which causative microorganisms are isolated in surveillance cultures on admission. 2. Secondary endogenous pneumonia, in which causative microorganisms are nosocomial pathogens not present on admission, but have colonized the patient during a hospital stay. 3. Exogenous pneumonia, in which caused by microorganisms not originally isolated from surveillance cultures, hence the patient is not a The time of onset for nosocomial pneumonia reflects possible etiologies, empirical antimicrobial treatment, and outcomes. Previously, ventilator-associated pneumonia has been categorized as either early or late onset. In an interesting trial by Truile and colleagues, 3 variables were significant for predicting infection with multi-drug-resistant: duration of mechanical ventilation, abbreviated as MV, equal to or greater than 7 days, odds ratio equal to 6, prior antibiotic use, odds ratio equal to 13.5, and prior use of broad-spectrum antimicrobial agents, odds ratio equal to 4.1. More recent reports challenge this classification. Indeed, investigators recently have found comparable microbial etiologies between patients with early or late onset ventilator-associated pneumonia. This may be related to the worldwide rise in multi-drug resistant and emphasizes that the local ICU ecology is the most important risk factor for acquiring multi-drug resistant pathogens, irrespective of the length of intubation. We will now focus on the epidemiology. Let's begin with incidence and associated burden. Nosocomial pneumonia is the second most common nosocomial infection and the leading cause of death from nosocomial infections among critically ill patients. Incidence ranges from 5 to more than 20 cases per 1,000 hospital admissions, with the highest rates in immunocompromised, surgical, and elderly patients. Approximately 1/3 of nosocomial pneumonias are acquired in the ICU, with ventilator-associated pneumonia being the majority of these ICU-acquired pneumonias. Epidemiology studies from United States report a ventilator-associated pneumonia incidence density between 2 and 16 episodes per 1,000 ventilator days. In comparison with previous reports, the incidence of ventilator-associated pneumonia is decreasing, likely due to better implementation of prophylactic strategies. Cook and colleagues estimated that the risk of ventilator-associated pneumonia is 3% during the first 5 days on mechanical ventilation, 2% from the 5th to the 10th days, and 1% for subsequent days. Nosocomial pneumonia, and particularly ventilator-associated pneumonia, increases the duration of hospitalization and healthcare costs. Worsened clinical outcomes associated with ventilator-associated pneumonia have been consistently reported throughout the years. As a result, mean hospital charges per ventilator-associated pneumonia patient have been estimated to increase by approximately $40,000. We will now focus on mortality. The crude mortality from nosocomial pneumonia may be as high as 30% to 70%. Several reports have estimated that 1/3 to 1/2 of all ventilator-associated pneumonia-related deaths are the direct result of the infection, with a higher mortality rate in cases caused by Pseudomonas aeruginosa and Aeronetobacter species. Attributable ventilator-associated pneumonia mortality has been defined as the percentage of deaths that would not have occurred in the absence of the infection. Recent studies have reappraised the impact of ventilator-associated pneumonia on mortality. In particular, as mentioned earlier, the risk of ventilator-associated pneumonia is time-dependent, possibly causing a significant time-dependent bias, because mortality and ICU discharge act as competing endpoints. Thus, the most recent studies reported an attributable mortality associated with ventilator-associated pneumonia of 10%, with surgical patients and patients with mid-range severity of illness at the highest associated risk. We will now discuss the pathogenesis. Extensive laboratory and clinical work have determined the key pathogenic mechanisms of ventilator-associated pneumonia. Pathogens must first gain access to the airways to cause pneumonia, and intubated patients are at high risk for aspiration of colonized oropharyngeal secretions. In healthy, non-intubated patients, when bacteria gain access to the respiratory tract, colonization is prevented through defense mechanisms, such as a cough, mucus clearance, and cellular and humoral immune responses. Critically ill and intubated patients are already at a high risk for infection because of underlying illness, comorbidities, malnutrition, and invasive devices or procedures. However, tracheal intubation is the conditio sine qua non for the development of ventilator-associated pneumonia, because it facilitates aspiration of pathogens and hinders intrinsic respiratory defenses. And now we will focus on the role of the endotracheal tube in the pathogenesis of ventilator-associated pneumonia. Pulmonary aspiration of the colonized oropharyngeal secretions across the endotracheal tube, cuff, is the main pathogenic mechanism for the development of ventilator-associated pneumonia. The most commonly used endotracheal tube for long-term mechanically ventilated patients comprises a high-volume, low-pressure, abbreviated as HVLP, cuff. High-volume, low-pressure cuffs were originally designed to prevent tracheal injury. However, the diameter of the high-volume, low-pressure cuff is 2 to 3 times larger than the tracheal diameter, so when the endotracheal tube cuff is inflated within the trachea, folds invariably form along the cuff surface, causing consistent aspiration of oropharyngeal secretions. Pathogens may also grow on the internal surface of the endotracheal tube and ultimately translocate into the lungs. Bacteria easily adhere to the endotracheal tube internal surface to form a structure called a biofilm, as shown in Figure 75.1. Biofilm is composed of sessile bacteria embedded within a self-produced exopolysaccharide matrix. Biofilm on the internal surface of an endotracheal tube can be identified early following tracheal intubation. Sessile bacteria undergo phenotypic differentiation from their planktonic counterparts to improve survival. Indeed, sessile bacteria are difficult to eradicate by the host's immune response or antibiotics. During mechanical ventilation, biofilm particles may dislodge into the airways as a result of the inspiratory airflow and invasive medical interventions, such as tracheal aspiration. Several studies have confirmed that the endotracheal tube biofilm constitutes a persistent source of colonization. Pause the video and carefully scrutinize Figure 75.1 illustrating laboratory studies to assess biofilm formation on the internal surface of the tracheal tube, following oropharyngeal challenge in pigs of Pseudomonas aeruginosa, strain Power 1, and 72 hours of mechanical ventilation before advancing to the next slide. We will now shift gears to sources of colonization. Patients are colonized exogenously by contaminated respiratory equipment, the ICU environment, and the hands of the ICU staff. Several reports have described ICU outbreaks due to colonized bronchoscopes, water supply, respiratory equipment, humidifiers, ventilator temperature sensors, respiratory nebulizers, and the contaminated ICU environment. Endogenous colonization is the primary pathogenic mechanism for ventilator-associated pneumonia development. In the critically ill patient, the oral flora shifts early to a predominance of aerobic gram-negative pathogens, Pseudomonas aeruginosa, and methicillin-resistant Staphylococcus aureus, abbreviated as MRSA. Pulmonary aspiration of oropharyngeal contents increases the risk for airway colonization and infection. Following aspiration and colonization of the airways, the occurrence of ventilator-associated pneumonia primarily depends on the size of the inoculum, functional status of the patient, and the competency of host defenses. There remains controversy regarding the exact sequence of colonization and source of infection in the pathogenesis of ventilator-associated pneumonia. Early studies by Feldman and colleagues found that in patients undergoing mechanical ventilation, the oropharynx is the first site to be colonized by pathogens, that is 36 hours, followed by the stomach, that is 36 to 60 hours, the lower respiratory tract, that is 60 to 84 hours, and the endotracheal tube thereafter, that is 60 to 96 hours. And now we will discuss oropharyngeal colonization. In ICU patients, several oropharyngeal defense mechanisms are dramatically altered. First, comorbidities and inherent patient characteristics, such as alcohol abuse, diabetes, and chronic obstructive pulmonary disease, COPD, are well-known risk factors for gram-negative oropharyngeal colonization. Elderly patients, patients with disabilities, and patients tracheally intubated for extended periods are at increased risk for overgrowth of oropharyngeal pathogens, because of their inability to carry out effective oral care. Additionally, the extensive use of antibiotics in critical care settings promotes overgrowth of oropharyngeal pathogens. Second, during critical illness, the antimicrobial effectiveness of saliva is highly impaired due to a dramatic reduction in the salivary flow, decreased pH, and increased amount of proteases released by host immune cells and periodontal bacteria. Bacteria that colonize the oropharynx also produce a large variety of hydrolases that lead to increased expression of key receptors for bacterial adhesion. Foria and collaborators found that prolonged ICU stay increased the risk for oropharyngeal colonization, which ultimately led to nosocomial pulmonary infection. Azarpaju and colleagues found evidence of an association of pneumonia with oral health, odds ratio equal to 1.2 to 9.6, depending on oral health indicators. Improved oral hygiene reduced the occurrence of respiratory infection among high-risk elderly adults. Interestingly, in a study by Heo, oral respiratory pathogens were often genetically identical to pathogens recovered from the lower airways, and rapid changes of bacterial species in both oral and pulmonary sites occurred. We will now focus on sinuses. The association between sinusitis and ventilator-associated pneumonia has long been debated. Several studies have confirmed that orotracheal as compared to nasotracheal intubation is associated with a decreased incidence of sinusitis and that the incidence of ventilator-associated pneumonia is lower in patients who do not develop sinusitis. A study by Holzapfel and colleagues evaluated the incidence of nosocomial maxillary sinusitis and pneumonia in patients who underwent either nasotracheal or orotracheal intubation. The authors found that sinusitis increased the risk of nosocomial pneumonia by a factor of 3.8. We will now switch gears to the stomach. According to the gastropulmonary hypothesis of colonization, the stomach of ICU patients is colonized by pathogens due to gastric alkalinization associated with enteral nutrition and drugs for prevention of gastrointestinal bleeding. Continuous gastroesophageal reflux facilitates translocation of microbes into the oropharynx, which is then aspirated across the endotracheal tube cuff. Early studies have shown that in tracheally intubated patients, gastric pH higher than 4 was consistently associated with gastric colonization. However, the association between gastric colonization and ventilator-associated pneumonia found in early studies has been challenged. Overall, this area remains highly controversial, and several studies have not found a relationship with bacteria causing ventilator-associated pneumonia as first originating in the stomach. We will now focus on impairment of respiratory defense during critical illness and tracheal intubation. In healthy subjects, the anatomic laryngeal barrier prevents aspiration of pathogen-laden oropharyngeal contents. Following intubation, the endotracheal tube completely bypasses these anatomic barriers. A cough is one of the most efficient mechanisms to prevent further translocation of pathogens that may have gained access to airways. Tracheal intubation prevents the closure of the glottis. Hence, it hinders cough. Moreover, intubated patients are often sedated and unable to generate high expiratory flows. Mucociliary clearance is the primary innate airway defense mechanism to clear pathogens. In young, healthy non-smokers, the mucociliary velocity ranges between 10 and 20 mm per minute. Studies in animals have shown that inflation of the endotracheal tube cuff lowers mucociliary velocity by 50% after only 2 hours. Clinical studies in critically ill patients have found similar reduced mucociliary velocity, that is 0.8 to 1.4 mm per minute, and higher risks for pulmonary complications. As previously mentioned, the daily hazard rate for developing ventilator-associated pneumonia is higher during the first days of mechanical ventilation. Investigators have found that a temporary immunoparalysis can be found early in the course of the critical illness and admission to the ICU. In particular, researchers have assessed human leukocyte antigen DR, abbreviated as HLA-DR, expression on peripheral monocytes as a marker of immune function. Low levels of human leukocyte antigen DR expression have been found in patients who subsequently developed nosocomial pneumonia. We will now discuss etiologic agents for nosocomial pneumonia. Nosocomial pneumonia may be caused by a variety of pathogens. Also, in many patients, more than one pathogen may be isolated. Microorganisms responsible for nosocomial pneumonia differ according to the ICU population, the duration of hospital and ICU stays, and the specific diagnostic method or methods used. Ventilator-associated pneumonia is commonly caused by aerobic pathogens, often multidrug resistant, including Pseudomonas aeruginosa, Acinetobacter species, Carbapenemus containing Klebsiella pneumoniae, and methicillin-resistant Staphylococcus aureus. Data from 7,087 infected patients, that is 63.5% with respiratory tract infection, from the extended prevalence of infection in intensive care, abbreviated as EPIC-2, study have confirmed that Pseudomonas species and Staphylococcus aureus are the most common isolated pathogens in ICUs. Esperati and colleagues prospectively evaluated 315 ICU patients with HAP admitted to an ICU. Among those, 52% were invasively ventilated, whereas 48% were either on spontaneous or non-invasive ventilation, abbreviated as NIV. Interestingly, the proportion of causative pathogens was similar between groups, except for a higher proportion of Streptococcus pneumoniae in patients not invasively ventilated. Thus, it seems that in ICU-acquired pneumonia, the overall frequency of multidrug-resistant pathogens and methicillin-resistant Staphylococcus aureus is sufficiently high to warrant the use of broad empirical therapy. The high rate of polymicrobial infection in ventilator-associated pneumonia has been shown repeatedly. Coombs and colleagues studied 124 ICU patients, of whom 52% had monomicrobial ventilator-associated pneumonia and 48% polymicrobial ventilator-associated pneumonia. In most patients, 2 different bacterial species were isolated, that is 34%. However, up to 4 different bacterial species coexisted in 7 patients, that is 6%. Interestingly, no differences were detected in mortality rate at 30 days among patients with polymicrobial or monomicrobial infection. A study by Teixeira and colleagues investigated risk factors for inadequate empirical antimicrobial therapy in 151 ICU patients and found that inadequate antimicrobial treatment was associated with polymicrobial ventilator-associated pneumonia. Odds ratio equal to 3.67, with a 95% confidence interval equal to 1.21 to 11.12, with a p-value equal to 0.02, and higher mortality. Underlying diseases may predispose patients to infection with specific organisms. Patients with COPD are at increased risk for Haemophilus influenza, Moraxella catarrhalis, Pseudomonas aeruginosa, or Streptococcus pneumoniae infections. Patients with acute respiratory distress syndrome, abbreviated as ARDS, are at higher risk for developing ventilator-associated pneumonia caused by Staphylococcus aureus, Pseudomonas aeruginosa, and Acinetobacter baumannii, and often in these patients, ventilator-associated pneumonia is caused by multiple pathogens. Finally, trauma and neurologic patients are at increased risk for Staphylococcus aureus, Haemophilus, and Streptococcus pneumoniae infections. Causative pathogens of ventilator-associated pneumonia that are potentially multi-resistant are Pseudomonas aeruginosa, methicillin-resistant Staphylococcus aureus, Azinetobacter ceces, Strenotophomonas multifilia, Burkholderia cepacia, and Klebsiella pneumoniae. Conversely, Streptococcus pneumoniae, Haemophilus influenza, methicillin-sensitive Staphylococcus aureus, abbreviated as MSSA, and antibiotic-sensitive Enterobacteriaceae are not considered multi-drug-resistant pathogens. In the majority of the cases, resistance to third- and fourth-generation cephalosporins in carbapenem-susceptible strains of Escherichia coli and Klebsiella pneumoniae is caused by the acquisition of plasmodic Ambler class or extended-spectrum beta-lactamases or AMP-C-like cephalosporinases. Resistance to carbapenems in Enterobacteriaceae is caused by the acquisition of plasmodic carbapenemases, either of Ambler class A, mainly Klebsiella pneumoniae carbapenemus, B, or D. Importantly, plasmids harboring extended-spectrum beta-lactamus, abbreviated as ESBL, encoding and/or carbapenemus encoding genes often carry other resistance genes, which ultimately confer pan-drug resistance. Conversely, carbapenem resistance in Pseudomonas aeruginosa and Azinetobacter baumannii may be caused by loss of outer membrane porins, hyperexpression of efflux pump systems, and carbapenemus production. In 2010, linezolid-resistant methicillin-resistant Staphylococcus aureus was reported, due to a plasmid harboring the chloramphenicol-fluorphenicol resistance gene. Patients at risk of being colonized by multi-drug-resistant pathogens are extremely heterogeneous, often present several comorbidities, and many receive antibiotics during their hospitalization. The incidence of multi-drug-resistant pathogens is also closely linked to local factors and varies widely from one institution to another. Therefore, clinicians must be aware of their ICU local ecology and antibiotic susceptibility to avoid the administration of inadequate initial antimicrobial therapy. Legionella pneumophila as the cause of nosocomial pneumonia should be considered, particularly in immunocompromised patients. Often, the source of legionellosis outbreaks within the hospital is a water system that has become colonized by the microorganism. A primary mechanism for ventilator-associated pneumonia development is through aspiration of oropharyngeal contents, and the oropharynx is highly colonized by anaerobes. Robert and colleagues studied 26 mechanically ventilated patients and found that 15 patients became colonized with 28 different anaerobic strains. Similarly, Dore al. found anaerobic bacteria in 30, that is 23%, of 130 patients diagnosed with ventilator-associated pneumonia, but always in association with aerobic pathogens. Importantly, empirical antibiotic therapy active against anaerobic bacteria appears to improve short-term outcomes in patients with ventilator-associated pneumonia. Nevertheless, the role of anaerobes in ventilator-associated pneumonia is still considered to be controversial. In particular, Marek and colleagues studied microbiology of 185 episodes of suspected ventilator-associated pneumonia through blind protected specimen brush, abbreviated as PSB, sampling and mini-BAL, and were unable to identify anaerobes as the causative pathogens of ventilator-associated pneumonia. Rarely, ventilator-associated pneumonia is caused by fungi. Candida species and Aspergillus fumigatus are the most commonly isolated fungi, predominantly in immunocompromised patients. Candida promotes the development of pneumonia by creating biofilms that facilitate bacterial colonization. Moreover, Candida seems to reduce host immune response. Thus, clinical studies have shown that Candida colonization increases the risk of ventilator-associated pneumonia by Pseudomonas aeruginosa. Yet, in a post-mortem study of patients with evidence of pneumonia at autopsy and isolation of Candida from respiratory samples, no case of Candida pneumonia was found. Interestingly, colonization by Candida has also been associated with longer mechanical ventilation, ICU and hospital stays, and in-hospital mortality. Some investigators argue that the presence of Candida is merely a marker of severity rather than a true etiologic factor for ventilator-associated pneumonia. Viruses may also cause ventilator-associated pneumonia. Herpes simplex virus type 1, abbreviated as HSV1, nosocomial pneumonia is more frequently reported in immunocompromised patients and patients with ARDS, major surgery, or extensive burns. Lute and colleagues demonstrated in 201 patients with clinical suspicion of ventilator-associated pneumonia that 21% had herpes simplex virus type 1 pneumonia. Several studies have reported a high incidence of active CMV infection in mechanically ventilated patients. Chich and colleagues studied 242 immunocompetent ICU patients and found active CMV infection in 39, 16%, individuals. At 28 days, only 15% of the patients with active CMV infection were weaned and alive, in comparison to 52% of patients free of CMV infection, with a p-value less than 0.001. We will now progress to prevention of nosocomial pneumonia. Nosocomial pneumonia is associated with high morbidity and mortality and constitutes an important burden for the healthcare system. Therefore, preventive strategies should be implemented to reduce the overall incidence of the disease, as shown in Box 75-1. The Institute for Healthcare Improvement recommends that approaches with proven efficacy in infection control should be implemented together as a bundle because combined, they are expected to result in a better outcome than when implemented individually. Designing a preventive bundle is just the first step and must be followed by a continuous assessment of healthcare personnel compliance and improvements to implement interventions. Several reports have found consistent reductions in the incidence of ventilator-associated pneumonia following the implementation of ventilator-associated pneumonia preventive bundles. Pneumonia. Pause the video and carefully scrutinize Box 75-1 summarizing preventive strategies for nosocomial. They include the following. 1. Implementation, as a bundle, of nosocomial pneumonia preventive strategies that have proven efficacy in reducing morbidity and mortality. 2. Implementation of educational programs for caregivers and frequent performance feedbacks and compliance assessment. 3. Strict alcohol-based hand hygiene. 4. Avoidance of tracheal intubation and use of non-invasive ventilation when indicated. 5. Daily sedation, vacation and implementation of weaning protocols. 6. No ventilatory circuit tube changes unless the circuit is soiled or damaged. 7. Use of tracheal tube with cuff made of novel materials and shapes. 8. Use of silver-coated tracheal tube. 9. Application of low-level PEEP during tracheal intubation. 10. Aspiration of subglottic secretions. 11. Internal cuff pressure maintained within the recommended range and carefully controlled during transport of patients outside ICU. 12. Oral care with chlorhexidine. 13. Avoid stress ulcer prophylaxis in very low-risk patients for gastrointestinal bleed, and consider use of sucralfate when indicated. 14. Semi-recumbent patient positioning. 15. Continuous lateral rotation therapy. 16. Post-pyloric feeding in patients who have impaired gastric emptying. And 17. SDD for patients requiring more than 48 hours of mechanical ventilation. And now we will switch gears to general prophylactic measures. Maintaining high levels of education among ICU personnel relating to ventilator-associated pneumonia pathophysiology and preventive strategies can be effective in reducing its incidence. Needleman et al. Studied administrative data from 799 hospitals in 11 states, covering 5,075,969 discharges of medical patients and 1,104,659 discharges of surgical patients, and found that a higher proportion of hours of care per day provided by registered nurses, compared to licensed practical nurses and nurses' aides, was associated with lower incidence of pneumonia. Adherence to simple infection control measures, such as alcohol-based hand disinfection, effectively reduces cross-transmission of pathogens and incidence of ventilator-associated pneumonia. The World Health Organization has endorsed hand hygiene as the single most important element of strategies to prevent healthcare-associated infections. Overall, most studies conducted in ICUs have shown consistent results and a temporal association between implementation of alcohol-based hand hygiene and reduction of nosocomial infections. Investigators demonstrated that patient transport outside the ICU was associated with increased risk for ventilator-associated pneumonia. Clinicians and nursing staff should carefully check the internal pressure of the endotracheal tube cuff prior to and during patient transport. Also, ventilator circuits should be carefully manipulated to prevent the aspiration of colonized fluids from within the circuit. Daily interruption or lightening of sedation and early mobilization, as well as avoidance of paralytic agents, is highly recommended to avoid impairment of respiratory defenses, prolonged tracheal intubation, and ventilator-associated pneumonia. There is evidence of shorter length of mechanical ventilation, reduced rate of failed extubation, and decreased incidence of ventilator-associated pneumonia when protocol-driven weaning from the ventilator is implemented. Morelich and colleagues randomized 385 patients to receive either a protocol-driven weaning procedure or standard care and found that duration of mechanical ventilation was decreased from a median of 124 hours for the control group to 68 hours in the protocol-driven weaning group, with a p-value equal to 0.0001. Moreover, a trend toward less ventilator-associated pneumonia was found in the treatment group, with a p-value equal to 0.061. We will now discuss non-invasive ventilation, abbreviated as NIV. Tracheal intubation and mechanical ventilation account for the main risk for nosocomial pneumonia and should therefore be avoided whenever possible. Non-invasive ventilation is an attractive alternative for patients with acute exacerbations of COPD or acute hypoxemic respiratory failure and for some immunocompromised patients with pulmonary infiltrates and respiratory failure. Non-invasive ventilation can also be safely used to facilitate early extubation and avoid continued invasive weaning. A meta-analysis confirmed that non-invasive weaning is associated with reduced mortality, ventilator-associated pneumonia, and length of stay in the ICU and hospital. Other reports have emphasized the role of non-invasive ventilation in preventing re-intubation in recently extubated patients at risk for relapse and respiratory failure. Kohlenberg and colleagues pooled data of 400 ICUs in Germany and found a mean pneumonia incidence of 1.58 and 5.44 cases per 1,000 ventilator days for non-invasive ventilation and invasive mechanical ventilation, respectively. Therefore, when indicated, non-invasive ventilation should be attempted to avoid tracheal intubation and reduce the overall duration of tracheal intubation. We will now focus on tracheal tube cuff. Currently, in critical care settings, patients are intubated with endotracheal tube comprising high-volume low-pressure cuffs. Upon inflation, folds form along the cuff surface, and colonized oropharyngeal secretions may leak through these folds. Novel endotracheal tube cuffs made of polyurethane, silicone, and latex have been developed and tested in the laboratory and clinical trials. In particular, the polyurethane cuff has a thickness of 5 to 10 micrometers, in comparison to 50 micrometers for PVC cuffs. Hence, upon inflation, smaller folds form with polyurethane cuffs, and aspiration of secretions above the cuff can be prevented or reduced. Some investigators have attempted to prevent aspiration by modifying the shape of the cuff. In comparison to standard cuffs with cylindrical shapes, cuffs designed with a smooth, tapering shape allow elimination of folds for a full circumference of the trachea or cuff contact zone, irrespective of the cuff material. A few studies in medical ICU patients have shown that polyurethane cuffs reduce risks of developing ventilator-associated pneumonia. The polyurethane cuffed endotracheal tube has also shown benefits in reducing early postoperative pneumonia in cardiac surgical patients. Interestingly, in a recent multi-center study, cuffs composed of cylindrical polyvinyl chloride, cylindrical polyurethane, conical polyvinyl chloride, or conical polyurethane were compared in the prevention of ventilator-associated pneumonia, and no benefits were found with the use of polyurethane or conical cuffs. Silicone and latex cuffs are low volume and low pressure and are potential alternatives to PVC cuffs since folds are never formed upon inflation within the trachea. In a clinical trial on patients undergoing anesthesia or admitted to the ICU, Young and colleagues demonstrated high effectiveness of a silicone cuff in reducing pulmonary aspiration. In our opinion, due to the lack of clear evidence on the benefits of these new cuffs, the use should be only limited to patients at very high risk of developing ventilator-associated pneumonia. It is important to maintain the internal endotracheal tube cuff pressure between 25 and 30 centimeters of water to prevent aspiration of contaminated secretions into the lower airways and tracheal injury. Several studies have demonstrated that frequently the endotracheal tube cuff was underinflated or hyperinflated using standard management. Continuous control of internal cuff pressure reduces risks of significant deflation and pulmonary aspiration. Ventilatory settings may play a role in the pathogenesis of ventilator-associated pneumonia. In particular, PEEP may decrease the incidence of ventilator-associated pneumonia by counteracting hydrostatic pressure exerted by oropharyngeal secretions above the endotracheal tube cuff, hence reducing pulmonary aspiration. Lucangelo and colleagues assessed the effects of 5 to 8 centimeters of water PEEP in normoxemic ventilated patients and showed a reduction in the rate of ventilator-associated pneumonia. Thus, in the absence of major contraindications, a low level of PEEP should be maintained to avoid pulmonary aspiration. We will now look at tracheal tubes coated with antimicrobial agents. Coating the endotracheal tube with antimicrobial agents, such as silver, is a promising strategy to prevent biofilm formation on its internal surface and ventilator-associated pneumonia. Olson and colleagues tested a silver-coated endotracheal tube in dogs challenged with Pseudomonas aeruginosa into the oropharynx. Using the new tube, the investigators were able to postpone colonization of the endotracheal tube inner surface and reduce pulmonary bacterial burden. Similarly, Berra and colleagues studied a silver sulfadiazine chlorhexidine-coated endotracheal tube in sheep. After 24 hours of mechanical ventilation, standard endotracheal tubes and ventilatory circuits were heavily colonized, whereas the novel coated endotracheal tube fully avoided colonization. Interestingly, the efficacy of silver-based coatings seems to decrease over time. Indeed, animal studies reported heavy colonization of silver-coated endotracheal tubes after 72 hours of mechanical ventilation. To date, only one laboratory study has shown the absence of endotracheal tube biofilm formation up to 168 hours of mechanical ventilation, when silver sulfadiazine endotracheal tubes were regularly cleaned with the mucus shaver. The North American silver-coated endotracheal tube, abbreviated as NASCENT, randomized trial compared the preventive effects of a silver-coated versus conventional endotracheal tube. The silver-coated endotracheal tube was associated with a lower incidence of microbiologically confirmed ventilator-associated pneumonia, that is 4.8% versus 7.5%, with a p-value equal to 0.03. for a relative risk reduction of 35.9%. A retrospective cohort analysis by Afesa and colleagues showed that the silver-coated endotracheal tube was associated with reduced mortality in patients with ventilator-associated pneumonia, 14% versus 36% in silver and control endotracheal tube, respectively, with a p-value equal to 0.03. Mortality was higher in those without ventilator-associated pneumonia. In conclusion, endotracheal tube coated with antimicrobial agents could reduce the incidence of ventilator-associated pneumonia, but the evidence supporting its use comes only from one study, with significant limitations. Thus, clinicians should carefully consider benefits and limitations of these endotracheal tubes and properly direct the use of silver-coated tubes to patients expected to be ventilated for longer periods of time and with higher risks for nosocomial pneumonia. Shaw and colleagues analyzed the cost-effectiveness of the silver-coated endotracheal tube and found that per each prevented ventilator-associated pneumonia, $12,840 was saved. And now we will discuss aspiration of subglottic secretions. Aspiration of colonized subglottic secretions through dedicated endotracheal tubes reduces hydrostatic pressure exerted above the cuff and potentially prevents leakage across the cuff. A meta-analysis has shown that drainage of subglottic secretions reduced the overall risk ratio, R, for ventilator-associated pneumonia by half. Risk ratio, 0.55, with a 95% confidence interval of 0.46 to 0.66, with a p-value less than 0.01. In a multi-center trial by Lacaide and colleagues, 333 patients were randomized to be intubated with either an endotracheal tube that allowed drainage of subglottic secretions or a standard endotracheal tube. Microbiologically confirmed ventilator-associated pneumonia occurred in 14.8% of the patients in the treatment group, compared to 25.6% of the patients intubated with a standard tube, with a p-value equal to 0.02. Interestingly, Subglottic secretion drainage has been consistently associated with tracheal injury in clinical and laboratory studies. And now we will look at tracheostomy. Tracheostomized patients present the same risks for aspiration of pathogen-laden secretions pulled above the cuff as orotracheally intubated patients. In the most recent meta-analysis that assessed outcomes of early versus late tracheostomy, early tracheostomy did not reduce the incidence of ventilator-associated pneumonia. Early tracheostomy may improve patient comfort, ability to communicate, capability for oral feeding, reduce the need for sedation and analgesia, and reduce airway resistance in comparison to standard endotracheal tubes. These factors are of paramount importance during the weaning period to shorten the duration of tracheal intubation. Next we will discuss ventilator circuit management. Clinical trials in adults and meta-analyses have demonstrated that a routine change of the ventilator circuit does not decrease risks for ventilator-associated pneumonia or costs. Therefore, circuits should not be changed unless the circuit is soiled or damaged. Importantly, inadvertent flushing of the contaminated condensate into the lower airways or nebulizers should always be avoided by careful emptying of ventilator circuits and water traps. The latest meta-analysis that assessed the effects of heated humidifiers, abbreviated as HH, and heat and moisture exchangers, abbreviated as HME, on prevention of nosocomial pneumonia showed no effect on pneumonia prevention. To date, neither humidification strategy can be recommended as a pneumonia prevention tool. However, it is rational to deliver inspiratory gases at body temperature or slightly below and at the highest relative humidity to prevent loss of heat and moisture from the airways, change in rheologic properties of secretions, and impairment of mucociliary clearance. Therefore, the use of heated humidifier is particularly indicated in patients with hypothermia, prolonged mechanical ventilation, thick secretions, and chronic respiratory disorders. Finally, studies testing less frequent changes of heat and moisture exchanges have not found increased risks for ventilator-associated pneumonia. Heat and moisture exchanges should be changed periodically, i.e., every 72 hours, to ensure good performance. Closed tracheal suctioning systems have been introduced in clinical settings to avoid adverse events associated with ventilator disconnection during open tracheal suctioning and exogenous contamination of suction catheters entering the endotracheal tube. 3 meta-analyses have compared the closed to the open tracheal suction system in mechanically ventilated patients and found no benefits of ventilator-associated pneumonia prevention. The use of a saline solution instilled into the endotracheal tube before tracheal suctioning remains controversial. A systematic review consistently found a decrease in patient oxygenation in most studies. Only one study found a lower incidence of microbiologically proven ventilator-associated pneumonia, saline instillation versus no treatment, 23.5% versus 10.8%, with a p-value equal to 0.008. Importantly, in sedated patients in the semi-recumbent position and with the endotracheal tube internal surface highly colonized, saline instillation may increase risks for translocation of pathogens into the airways. And now we will look at body position. Early studies demonstrated that intubated patients are at higher risk for gastropulmonary aspiration when placed in the supine position, that is 0 degrees, as compared with a semi-recumbent position, that is 45 degrees. One randomized trial demonstrated a reduction in the incidence of ventilator-associated pneumonia in patients positioned in the semi-recumbent position compared with patients completely supine, particularly during enteral feeding. A later randomized trial found limited feasibility of the intervention and no differences in ventilator-associated pneumonia incidence. Thus, as strongly suggested by the American and European guidelines, intubated patients should be preferentially kept in the semi-recumbent position, that is 30 to 45 degrees, rather than supine, that is 0 degrees, especially when receiving enteral feeding. Laboratory reports have challenged the preventive benefits of the semi-recumbent position. Theoretically, in tracheally intubated patients, a tracheal orientation above horizontal might facilitate aspiration across the endotracheal tube cuff. Conversely, laboratory studies consistently found that the lateral Trendelenburg position enhances mucus drainage and decreases risks for ventilator-associated pneumonia. Currently, a multi-center clinical trial is testing in critically ill patients the efficacy, safety, and feasibility of the lateral Trendelenburg position in the prevention of ventilator-associated pneumonia, available from clinicaltrials.gov, NLM identifier, NCT011385540. We will now focus on the rotating bed. Several ICU beds permit the rotation of patients in the longitudinal axis from one lateral position to the other and reduce extravascular lung water, improve the ventilation-perfusion ratio, and enhance mobilization of airway secretions. Meta-analyses have shown a significant reduction in the incidence of ventilator-associated pneumonia in patients undergoing rotation therapy. Staudinger and colleagues studied the effects of continuous lateral rotation therapy and found a ventilator-associated pneumonia incidence of 11% in the rotation group and 23% in the control group, with a p-value equal to 0.048. The authors also found that the duration of ventilation, that is 8 ± 5 versus 14 ± 23 days, with a p-value equal to 0.02, and length of stay, that is 25 ± 22 days versus 39 ± 45 days, with a p-value equal to 0.01, were significantly shorter in the rotational group. In conclusion, in patients at a higher risk for prolonged immobilization and respiratory infection, continuous lateral rotation therapy should be considered for exerting additive effects to other preventive measures for ventilator-associated pneumonia. And now we will discuss stress ulcer prophylaxis and enteral feeding. Sucralfate, histamine type 2 blockers, also called H2 blockers, or proton pump inhibitors, also called PPIs, are the most common medication for stress ulcer prophylaxis. Sucralfate is the only treatment that does not cause gastric alkalinization. Early studies found a higher incidence of pneumonia in patients with alkalinized gastric contents, whereas others have not. Cook and colleagues found a higher risk of GI bleeding using sucralfate and no significant difference in ventilator-associated pneumonia incidence, 19.1% and 16.2% in patients treated with H2 blockers or sucralfate, respectively. Likewise, in a recent meta-analysis, proton pump inhibitors were more effective than H2 blockers at reducing upper gastrointestinal bleeding, without differences in ventilator-associated pneumonia, relative risk equal to 1.06, with a 95% confidence interval of 0.73 to 1.52, with a p-value equal to 0.76. In conclusion, GI bleeding is a serious complication in critically ill patients. The actual risk for ventilator-associated pneumonia is unknown when accurate methods of enteral feeding, i.e., avoiding large gastric residual volumes, or other preventive measures are used in combination with stress ulcer prophylaxis. Therefore, clinicians must weigh the potential benefit of sucralfate, with potentially less ventilator-associated pneumonia and more GI bleeding, versus H2 blockers or proton pump inhibitor, with potentially more ventilator-associated pneumonia and less GI bleeding, and probably limit stress ulcer prophylaxis to high-risk patients. Enteral nutrition has been considered a risk factor for the development of ventilator-associated pneumonia, because of increased risks for gastric alkalinization, gastroesophageal reflux, and gastropulmonary aspiration. However, its alternative, parenteral nutrition, is associated with higher risks for catheter-related infections, complications of line insertions, higher costs, and loss of intestinal villus architecture, which may facilitate enteral microbial translocation. A large meta-analysis of 11 studies comprising more than 500 critically ill patients found that the use of parenteral nutrition was associated with more infectious complications, compared to early enteral nutrition, odds ratio equal to 1.47, with a 95% confidence interval of 0.9 to 2.38, with a p-value equal to 0.12. Conversely, studies in medical ICU patients have demonstrated a higher risk for ventilator-associated pneumonia with early enteral feeding. Therefore, in medical ICU patients, the benefits of early nutrition should be balanced with associated increased risks for ventilator-associated pneumonia. Many ICU patients present impaired gastric emptying. Hence, the placement of the feeding tube beyond the pylorus has the potential to achieve nutrition goals without increased risks for gastropulmonary aspiration. The most recent meta-analysis by Jeong and colleagues found that small bowel feedings were associated with a lower incidence of pneumonia, R equal to 0.63, with a 95% confidence interval equal to 0.48 to 0.83, with a p-value equal to 0.001. In an interesting report by Davies and collaborators, in mechanically ventilated patients with mildly elevated gastric residual volumes and already receiving nasogastric nutrition, early post-pyloric nutrition did not increase energy delivery or reduce the frequency of pneumonia. Therefore, post-pyloric feeding should be preferred only when impaired gastric emptying is present. Finally, a recent study challenged the utility of routine monitoring of residual gastric volume in 449 patients receiving invasive mechanical ventilation and early enteral nutrition. Ventilator-associated pneumonia occurred in 16.7% of the patients without routine monitoring, in comparison with 15.8% in the control group. Modulation of oropharyngeal and gastrointestinal colonization. Given the pivotal role of oropharyngeal colonization in the development of ventilator-associated pneumonia, many decontamination strategies have been developed, which include hand washing, oral hygiene and tooth brushing, selective oral decontamination with topical non-absorbable antibiotics, and oropharyngeal rinsing with antiseptics. Chlorhexidine is a cationic chlorophenyl bis-biguanide antiseptic that has long been used as an inhibitor of dental plaque formation and gingivitis. A meta-analysis of studies assessing the benefits of chlorhexidine on the reduction of ventilator-associated pneumonia reported fewer lower respiratory tract infections in cardiac surgery patients, R equal to 0.56, with a 95% confidence interval of 0.41 to 0.77, without a significant mortality difference, R equal to 0.88, with a 95% confidence interval of 0.25 to 2.14. Results in non-cardiac ICU populations are inconsistent. Most of the studies described earlier used chlorhexidine concentrations up to 0.2%. This concentration may not be effective in most ICU patients with high levels of oropharyngeal colonization. Studies have demonstrated significant reductions in ventilator-associated pneumonia rates when chlorhexidine concentration was increased to 2%. Therefore, oral decontamination with chlorhexidine should be routinely used, specifically in cardiothoracic patients. In other ICU populations, the use of higher chlorhexidine concentrations could be a promising option. Alternatively, some investigators recently tested once-daily bathing of all patients with disposable cloths impregnated with 2% chlorhexidine as a preemptive strategy for nosocomial infections, but they did not find any significant benefit with this approach. Selective digestive decontamination, abbreviated as SDD, comprises a combination of non-absorbable antibiotics against gram-negative pathogens, i.e., tobramycin and polymycin E, plus either amphotericin B or nystatin. These agents are administered into the GI tract to prevent oropharyngeal and gastric colonization with aerobic gram-negative bacilli and candida species while preserving the anaerobic flora. Some regimens include a short course of systemic antibiotics, i.e., cefotaxime. Selective digestive decontamination was originally applied to oncologic and hematologic patients with severe immunosuppression. In the early 1980s, Stoutenbeek introduced this practice into critical care medicine. Since then, a remarkable number of clinical trials and meta-analyses confirmed the benefits associated with the use of selective digestive decontamination, which was associated with a reduction in the incidence of ventilator-associated pneumonia, bacterial bloodstream infections, and mortality. Currently, selective digestive decontamination is primarily applied in European centers with low levels of multidrug resistant. Randomized clinical trials and meta-analyses confirmed that selective digestive decontamination confers protection against nosocomial pneumonia. Several factors should be taken into account before extending its use worldwide. First, the most recent investigations on the intestinal microbiota highlight the variability, interactions, and complexity of gastrointestinal bacterial colonies, and systemic consequences of changes in gut colonization. Indeed, it is known that more than 10–11 bacteria per gram of feces, comprising more than 1,000 different species, are present in our intestinal system. Large inter-individual variations in bacterial patterns are evident even among humans living in the same geographic region. With the advent of individualized medicine, the use of a unit-wide single selective digestive decontamination regimen for all ICU population subtypes seems far-fetched. In addition, even the selectivity of selective digestive decontamination against aerobic gram-negative bacteria has been challenged. Thus, the impact of selective digestive decontamination on the intestinal microbiota and the resulting alterations of bacterial diversity need further evaluation. Second, one of the most recurrent arguments for not using selective digestive decontamination is that microorganisms not addressed by the regimen may be selected, i.e., methicillin-resistant Staphylococcus aureus and Enterococcus species. Or multi-drug resistant for the applied antibiotics may increase. A recent study demonstrated an increase in anaerobic flora antibiotic resistance genes during selective digestive decontamination, particularly highly transferable genes conferring resistance to aminoglycosides. In line with these results, Oostdijk and collaborators found increases in aminoglycoside-resistant gram-negative bacteria during selective digestive decontamination use. Finally, in one older study by the same group that explored recolonization following selective digestive decontamination, increased intestinal colonization with gram-negative bacteria resistant to ceftazidime, tobramycin, or ciprofloxacin was found. Likewise, resistance to ceftazidime increased gradually in the respiratory tract during selective digestive decontamination and even further post-intervention, for all three antibiotics. This suggests that there are still several unknown effects of selective digestive decontamination that need to be addressed. An ongoing European trial is addressing these questions. The R-NOSIS, an abbreviation for resistance in gram-negative organisms, studying intervention strategies, is evaluating the most effective measures to reduce infections caused by multi-drug-resistant pathogens and to understand the ecologic effects of decolonization strategies in patients admitted to the ICU. Available from https://www.clinicaltrials.gov/ct2/show, NCT02208154. Term equals Bonton and rank equals 2. Only one study has demonstrated that a short course of cefuroxime in patients with structural coma or severe burns was an effective prophylactic strategy to decrease the ventilator-associated pneumonia rate. However, routine use of parenteral antibiotics is not recommended until more data become available. Several clinical trials have attempted to modify GI and oropharyngeal growth of pathogens through the use of probiotics. Probiotics are microorganisms that can be administered either as individual strains or in various combinations. These microorganisms are often administered with non-digestible food ingredients that facilitate bacterial growth and activity, prebiotics. Products containing both probiotics and prebiotics are called synbiotics. The latest meta-analysis on the effects of probiotics suggests that probiotics may reduce the incidence of ventilator-associated pneumonia. The quality of the evidence is low and is lacking to draw firm conclusions on this subject. And now we will progress to the diagnosis of ventilator-associated pneumonia. The diagnosis of ventilator-associated pneumonia is a controversial issue. Clinical signs suggestive of pneumonia, such as fever, tachycardia, and leukocytosis, are nonspecific in critically ill patients. Moreover, particularly in ventilated patients with bronchiectasis and/or COPD, the chest radiograph is difficult to interpret, and it may not reveal subtle lung infiltrates, which are only detected by computed tomography, CT, scans. When infiltrates are evident, the differential diagnosis is challenging, i.e., cardiogenic and non-cardiogenic pulmonary edema, pulmonary contusion, and atelectasis. Few studies have examined the accuracy of portable chest radiographs in the diagnosis of ventilator-associated pneumonia. In mechanically ventilated patients with autopsy-proven ventilator-associated pneumonia, no single radiographic sign had a diagnostic accuracy greater than 68%. In patients with ARDS, marked heterogeneity of radiographic abnormalities has been reported. A clinical study showed the presence of lung infection in only 42% of the patients with clinically suspected ventilator-associated pneumonia. The presence of air bronchograms may increase the specificity of chest radiographs in ARDS patients. The Clinical Pulmonary Infection Score, abbreviated as CPIS, is based on 6 clinical assessments, as shown in Table 75.1. The clinical pulmonary infection score showed a good correlation, R equal to 0.84, with a p-value less than 0.0001, with quantitative bacteriology of BAL samples. Moreover, a value equal to or greater than 6 was the threshold to accurately identify patients with pneumonia. The value of clinical pulmonary infection score remains to be validated in a large prospective study, especially in patients with bilateral pulmonary infiltrates. The presence of bacteria in the lower airways of intubated patients is not sufficient to diagnose ventilator-associated pneumonia, because it could be only non-pathogenic colonization or ventilator-associated tracheobronchitis. Cultures of endotracheal aspirate from patients with respiratory failure and histologically documented pneumonia, simultaneously obtained from the trachea and lung tissue, agreed in only 40% of cases, with a 82% sensitivity and 27% specificity. Similarly, in another study, only 23% of colonized patients subsequently developed ventilator-associated pneumonia. Many sampling procedures of respiratory secretions, such as sputum collection, endotracheal aspirates, BAL, and PSB, are available. In addition, there are several microbiological techniques, including gram staining and intracellular organism count, for specimens obtained via BAL. Each diagnostic technique has advantages as well as limitations and provides different diagnostic specificity and sensitivity. Qualitative cultures of endotracheal aspirates have a high percentage of false positive results. Conversely, quantitative culture techniques are more reliable if appropriate cutoff criteria are applied. When patients develop pneumonia, pathogens are present in the lower respiratory tract secretions at concentrations of at least 10 power 5 to 10 power 6 colony-forming units per milliliter. The current diagnostic threshold proposed for tracheal aspirates is 10 power 6 colony-forming units per milliliter. Similarly, PSB collects between 0.001 and 0.01 milliliter of secretions. Therefore, the presence of more than 10 power 3 bacteria in the originally diluted sample, 1 milliliter, represents 10 power 5 to 10 power 6 colony-forming units per milliliter in pulmonary secretions. Finally, 10 power 4 colony-forming units per milliliter is considered the cutoff for BAL, which collects 1 milliliter of secretions in 10 to 100 milliliters of effluent. In one study, only 40% of the microorganisms cultured in endotracheal aspirate samples coincided with those obtained from PSB specimens. Also, when quantitative cultures of different lower respiratory tract specimens were compared with post-mortem quantitative lung biopsy cultures, all techniques for detecting ventilator-associated pneumonia were of limited value. A major problem in the management of patients with suspicion of ventilator-associated pneumonia is the use of antibiotics. The indiscriminate administration of antimicrobial agents for patients in the ICU may contribute to the emergence of multi-drug-resistant pathogens and increase the risk of superinfections with increased morbidity and mortality, as well as expose the patient to antibiotic-related adverse effects and higher costs. On the other hand, correct and prompt treatment of pneumonia results in better patient survival. Inadequate empirical antibiotic treatment, initiated before obtaining the results of cultures from respiratory secretions, was associated with greater hospital mortality compared with antibiotic regimens that provided adequate antimicrobial coverage based on microbiological culture results. However, the choice of initial antibiotic treatment is often difficult due to previous antibiotic treatment, prevalence of multidrug-resistant pathogens and colonizing pathogens. Recently, several alternative techniques to perform microbial cultures have been developed that achieve a more rapid and accurate diagnosis of nosocomial pneumonia, i.e., high multiplexing real-time polymerase chain reaction arrays and fluorescent in situ hybridization of bacteria. These methods proved to be feasible for rapidly detecting causative pathogens. Additionally, efforts have been made to detect rapidly the most important multidrug-resistant genes, such as MAKE-A, BLA-KPC, BLA-IMP, BLA-VIM, and BLA-OXA. Finally, a Spanish study tested a rapid E-test antibiogram for 6 antibiotic agents that could provide antibiotic susceptibility within 24 hours and found that the use of this technique resulted in more appropriate and reduced use of antibiotics in ventilator-associated pneumonia patients. Pause the video and carefully scrutinize Table 75(1) summarizing the clinical pulmonary infection score, abbreviated as CPIS, before advancing to the next slide. And now we will focus on ventilator-associated events surveillance algorithm. The Centers for Disease Control introduced the ventilator-associated events, abbreviated as VAE, surveillance definition algorithm to monitor complications in mechanically ventilated patients, as shown in Figure 75(2). This new algorithm was developed to monitor objectively pulmonary complications associated with worse outcomes in mechanically ventilated patients. Importantly, reports demonstrated poor concordance between infection-related ventilator-associated condition, abbreviated as IVAC, possible and probable ventilator-associated pneumonia, and ventilator-associated pneumonia diagnosed with standard criteria. In a study by Boudma and collaborators, sensitivity and specificity of diagnosing ventilator-associated pneumonia were 0.92 and 0.28 for the ventilator-associated condition, and 0.67 and 0.75 for infection-related ventilator-associated complication, respectively. Boyer and colleagues studied 1209 patients ventilated for equal to or greater than 2 calendar days with 5.5% ventilator-associated event. The most common causes of ventilator-associated conditions included infection-related ventilator-associated conditions, that is 50.7%, ARDS, that is 16.4%, pulmonary edema, that is 14.9%, and atelectasis, that is 9%. The sensitivity of the ventilator-associated event algorithm for the detection of ventilator-associated pneumonia was only 25.9%, with a 95% confidence interval of 16.7% to 34.5%. Thus, the ventilator-associated event algorithm should be considered as a powerful benchmarking tool, but with marginal value for the diagnosis of ventilator-associated pneumonia. We will now progress to diagnostic strategies for hospital-acquired pneumonia. An ideal diagnostic strategy for patients with clinical suspicion of hospital-acquired pneumonia should reach the following objectives. 1. Accurately identify patients with true pulmonary infection and isolate the causative microorganisms to initiate promptly appropriate antimicrobial treatment and subsequently to optimize therapy based on the susceptibility of the pathogens. 2. Identify patients with extrapulmonary sites of infection. 3. Withhold and/or withdraw antibiotics in patients without infection. The diagnosis of nosocomial pneumonia begins with clinical suspicion. The presence of a new or progressive radiographic infiltrates plus at least 2 of 3 clinical criteria, fever or hypothermia, leukocytosis or leukopenia, and purulent secretions, represents the starting point to begin diagnostic procedures. Two diagnostic algorithms can be used when there is clinical suspicion of nosocomial pneumonia. The clinical approach recommends treating every patient with suspicion of having a pulmonary infection with new antibiotics even when the likelihood of infection is low, as shown in Figure 75.3. However, samples of respiratory secretions, e.g., endotracheal aspirate or sputum, should be obtained before the initiation of antibiotic treatment. In this strategy, the selection of an appropriate empirical therapy is based on risk factors and local resistance patterns. The etiology of pneumonia is defined by semi-quantitative cultures of endotracheal aspirates or sputum, with an initial microscopic examination of the Gram stain. Antimicrobial therapy is adjusted according to culture results or the clinical response. The semi-quantitative culture of tracheal aspirates has the advantage that no specialized microbiological techniques are required and the sensitivity is high. This clinical strategy provides antimicrobial treatment to the majority of the patients with suspicion of HAP and yields a low rate of false negatives. If the tracheal aspirate culture does not demonstrate pathogens and the patient has not received new antibiotics within the previous 72 hours, the diagnosis of pneumonia is unlikely. This strategy is useful in centers where bronchoscopic methods are not always available. The main drawback of this strategy is that the high sensitivity of semi-quantitative cultures of tracheal aspirates leads to an overestimation of the incidence of hospital-acquired pneumonia and overuse of antibiotics. The bacteriologic strategy is based on the results of quantitative cultures of lower respiratory secretions, as shown in Figure 75.4. The procedure used to collect the samples, endotracheal aspirate, BAL, or PSB, may be invasive, bronchoscopic, or non-invasive, blind procedures. The bacteriologic strategy attempts to identify accurately patients with true hospital-acquired pneumonia so that only infected patients are treated and clinical outcomes are improved. Such a strategy reduces the risks for overuse of antibiotics, since quantitative cultures yield fewer microorganisms above the threshold, in comparison to semi-quantitative cultures. Among the disadvantages of the bacteriologic strategy is the possibility of obtaining false negative results that lead to delayed antibiotic treatment in a patient with pneumonia. Moreover, results using the bacteriologic strategy may lack reproducibility, and often no microbiological information is available at the time of initiation of empirical antibiotic therapy. 4 randomized controlled trials have assessed the impact of diagnostic strategies on antibiotic use and outcome in patients with clinically suspected ventilator-associated pneumonia. In 3 small studies, invasive diagnostic techniques resulted in a greater number of antibiotic changes than non-invasive techniques. However, no differences in mortality and morbidity were found when either invasive, PSB and/or BAL, or non-invasive, quantitative endotracheal aspirate cultures, techniques were used. By contrast, a larger trial showed a reduction in mortality, reduced use of antibiotics, and increased number of antibiotic-free days using invasive diagnostic techniques. This study was limited, however, by the use of qualitative cultures of tracheal aspirates, thereby limiting comparison with other clinical trials. Irrespective of the methods used to obtain respiratory samples, it is strongly recommended that samples be obtained before starting new antibiotics, or a lower threshold should be used in patients with recent antibiotic changes. A clinical trial compared the quantitative culture of BAL fluid and culture of endotracheal aspirate in critically ill patients with suspected ventilator-associated pneumonia. This study was part of a larger 2x2 factorial design, also comparing empirical antimicrobial monotherapy, a carbapenem, and combination therapy, a carbapenem plus a fluoroquinolone. A total of 740 patients in 28 ICUs throughout Canada and the United States were enrolled, and the authors found no difference in the 28-day mortality rate between the BAL group and the endotracheal aspiration group, 18.9% and 18.4%, respectively, with a p-value equal to 0.94. The BAL group and the endotracheal aspiration group also had similar rates of targeted therapy and days alive without antibiotics. At least 40% of the screened patients were excluded because they were at risk for colonization with Pseudomonas species or methicillin-resistant Staphylococcus aureus or were immunosuppressed. Therefore, translation of these findings into clinical practice is challenging, because many ICU patients evaluated for suspected ventilator-associated pneumonia fall into these categories. Last, in the latest meta-analysis, no differences using quantitative cultures versus qualitative cultures in mortality rates, R equal to 0.91, with a 95% confidence interval of 0.75 to 1.11. The number of days on mechanical ventilation, the length of ICU stay, or antibiotic changes were found. Likewise, there was no effect of invasive versus non-invasive diagnostic methods. And now we will consider practical implementation of a diagnostic strategy in suspected ventilator-associated pneumonia. In clinical practice, the development of local clinical guidelines can combine both clinical and bacteriologic strategies, as shown in Table 75-2. The diagnostic protocol begins with clinical suspicion of a nosocomial respiratory infection, as shown in Figure 75-5. In mechanically ventilated patients, the presence of an infiltrate on chest radiograph differentiates between the possible presence of pneumonia and tracheobronchitis. The next step is to sample the lower respiratory tract, see Table 75-3, to identify the causative microorganism. Respiratory tract specimens can be obtained by expectoration, bronchial aspirate, BAL, or PSB. The latter two techniques can be performed with bronchoscopy or blindly. Several other samples should also be collected, as noted in Table 75-2. With clinical suspicion of pneumonia, clinical pulmonary infection score should be calculated to improve the objective assessment of the clinical parameters, as shown in Table 75-1. Pause the video and carefully scrutinize Figure 75-2 illustrating ventilator-associated events surveillance protocol before advancing to the next slide. Pause the video and carefully scrutinize Figure 75-2 illustrating ventilator-associated events surveillance protocol before advancing to the next slide. Pause the video and carefully scrutinize Figure 75-3 illustrating clinical non-invasive strategy for diagnosis and management of ventilator-associated pneumonia before advancing to the next slide. Pause the video and carefully scrutinize Figure 75-4 illustrating invasive and quantitative culturing strategy for diagnosis and management of ventilator-associated pneumonia before advancing to the next slide. Pause the video and carefully scrutinize Table 75.2 summarizing diagnostic protocol to combine clinical and bacteriologic strategies for the diagnosis of ventilator-associated pneumonia before advancing to the next slide. Pause the video and carefully scrutinize Figure 75.5 illustrating clinical suspicion of nosocomial respiratory infection before advancing to the next slide. Pause the video and carefully scrutinize Figure 75.6 illustrating the evolution of potentially pathogenic microorganisms present in oropharyngeal flora, related to comorbidity, antibiotic treatment, and colonization pressure before advancing to the next slide. Pause the video and carefully scrutinize Box 75.2 summarizing risk factors for multi-drug resistant pathogens causing nosocomial pneumonia before advancing to the next slide. Pause the video and carefully scrutinize Table 75.3 summarizing initial empirical antibiotic treatment in nosocomial and ventilator-associated pneumonia of early onset in patients without risk factors for infection by multi-drug resistant pathogens before advancing to the next slide. Pause the video and carefully scrutinize Figure 75.7 illustrating an algorithm for the treatment of patients with suspicion of nosocomial respiratory infection before advancing to the next slide. We will now discuss the treatment. Once the clinical decision to initiate antimicrobial therapy has been made, the following issues should be considered to achieve the best antimicrobial efficacy and reduce overuse of antibiotics. 1. The most likely etiologic microorganisms. 2. Choice of the empirical antimicrobials likely to be active against these microorganisms. And 3. Adjustment of therapy following microbiologic results and duration of treatment. And now we will discuss likely etiologic microorganisms. As detailed in previous paragraphs, microorganisms causing ventilator-associated pneumonia originate from the oropharyngeal flora of the patient. Underlying chronic diseases, specific risk factors, acute inflammatory processes, and factors specific to each hospital or ICU can facilitate abnormal bacterial colonization of the oropharynx and may predispose patients to infection with specific organisms. Therefore, the selection of initial antimicrobial therapy must be tailored to the local prevalence of pathogens and antimicrobial patterns of resistance at each institution. The dynamics of change of oropharyngeal flora during hospital stay can be described as follows, as shown in Figure 75.6. 1. Healthy subjects are colonized with normal oropharyngeal flora in which pathogenic microorganisms, such as Streptococcus pneumoniae, group A Streptococci, or Meningococci may be transiently found. 2. Patients with chronic comorbidities or an acute inflammatory process have impairment of normal immune responses. As a result, Staphylococcus aureus and Enterobacteriaceae can colonize the oropharynx. 3. Patients who have received antibiotic treatment become colonized with resistant pathogens, including extended-spectrum beta-lactamus plus Enterobacteriaceae, Enterobacter species, Pseudomonas aeruginosa, or methicillin-resistant Staphylococcus aureus. 4. Patients who have received broad-spectrum antibiotics for more than 7 days are often colonized by multi-drug-resistant microorganisms, i.e., Aeronetobacter baumannii, Stenotrophomonas multifilia, Burkholderia cepacia, and gram-positive microorganisms. Changes in the oropharyngeal flora tend to occur progressively such that the presence of microorganisms during one stage often overlaps with the next stage. And now we will discuss the choice of empirical antimicrobials likely to be active against causative microorganisms. The latest guidelines of the American Thoracic Society and Infectious Diseases Society of America, ATS, IDSA, for the management of adult patients with nosocomial pneumonia recommend that the selection of empirical antibiotic therapy for each patient should be based on the timing of onset and presence of risk factors for multi-drug resistant pathogens. Risk factors for multi-drug resistant pathogens defined by the ATS, IDSA guidelines are summarized in Box 75-2. An algorithm for the initial management of patients with nosocomial respiratory infection and selection of appropriate antimicrobials is shown in Figure 75-7. The antibiotics recommended by the latest ATS, IDSA guidelines are shown in Tables 75-3 and 75-4. Adequate dosing of antibiotics for empirical therapy is summarized in Table 75-5. Broad-spectrum empirical antibiotic therapy should be rapidly de-escalated as soon as microbiological data become available to limit the emergence of resistance in the hospital. Figure 75-7, Table 75-3, and Table 75-4 detail empirical therapy, which should be based on patients' risk of colonization by multi-drug resistant organisms. As for the need for dual therapy against gram-negative pathogens, in a meta-analysis by Arts et al., 11 trials randomizing 1805 patients were evaluated. There was no mortality difference for patients receiving monotherapy versus combination therapy, R equal to 0.94, with a 95% confidence interval of 0.76 to 1.16. Likewise, there was no significant difference in treatment failure in patients with clinically suspected pneumonia, R equal to 0.88, with a 95% confidence interval of 0.72 to 1.07, Figure 75-5, or microbiologically proven pneumonia, R equal to 0.86, with a 95% confidence interval of 0.63 to 1.16. And now we will switch gears to nebulized antibiotics. Intravenous administration of antibiotics for nosocomial pneumonia has several limitations, including insufficient lung distribution, development of adverse side effects, and selective pressure for development of multi-drug resistant. Additionally, intravenous antibiotics are often underdosed in critically ill patients, due to sepsis-related higher volumes of distribution and hyperdynamic states. Administration of nebulized antibiotics is a potential therapeutic alternative to overcome these limitations. Additionally, systemic exposure to antibiotics and potential adverse effects are dramatically reduced. Finally, nebulized antibiotics can reduce the risk of developing multi-drug resistant infections. In laboratory models, nebulized amikacin reached pulmonary concentrations 30 times higher than intravenous administration. In a pivotal study by Liu and colleagues, 20 patients with susceptible or intermediate resistant gram-negative pathogens received nebulized ceftazidime and amikacin, while 17 patients infected with susceptible strains received intravenous ceftazidime and amikacin. After 8 days of treatment, the cure rate was similar between groups. However, acquisition of treatment-associated antibiotic resistance was higher in the intravenous group. In a later study, Niederman and colleagues randomized 69 mechanically ventilated patients with gram-negative ventilator-associated pneumonia to receive aerosolized amikacin concomitantly with systemic antibiotics. They found that amikacin distributed well throughout the lung parenchyma, with high tracheal and alveolar levels, but with a serum concentration below the renal toxicity threshold. Recently developed nebulizers increased the lung deposition of the aerosolized antibiotic dose by up to 60%. Several factors play a critical role in lung deposition of nebulized antibiotics during mechanical ventilation. First, the extent and severity of lung infection critically affect lung distribution of nebulized antibiotics. Second, vibrating plate nebulizers increase the efficiency of aerosol delivery to 40% to 60%. Finally, humidification and angular geometry of the ventilatory circuit should be taken into account during nebulization. In addition, ventilatory settings that ensure laminar inspiratory flow provide better distal lung deposition of aerosol particles. And now we will discuss antimicrobial therapy in special situations. In geographic areas with a documented presence of community-acquired methicillin-resistant Staphylococcus aureus, severe pneumonia with radiologic images of cavitation and presence of gram-positive cocci in respiratory secretions, empirical treatment with linezolid or vancomycin may be appropriate. Recently, an outbreak of methicillin-resistant Staphylococcus aureus and linezolid-resistant Staphylococcus aureus, abbreviated as LRSA, was reported in an intensive care department of a 1,000-bed tertiary care university teaching hospital in Madrid, Spain, and was associated with nosocomial transmission and extensive usage of linezolid. Tigecycline may be a useful alternative in this setting, although clinical experience is scanty. Infections by Legionella pneumophila serogroup 1 can be diagnosed by a Legionella urinary antigen test. This test should be routinely obtained if the hospital water supply is known to be colonized with Legionella pneumophila serogroup 1. A fluoroquinolone or a macrolide would be an appropriate treatment for Legionella pneumophila infection. Next we will discuss modifications of therapy and duration of treatment. A suggested flowchart for the follow-up of patients with nosocomial pneumonia is shown in Figure 75.8. After 72 hours, treatment should be adjusted based on microbiological results. The initial beta-lactam should be continued if the microorganism is susceptible to the empirical beta-lactam originally prescribed. If not, another beta-lactam should be introduced. The empirical antibiotic against methicillin-resistant Staphylococcus aureus should be discontinued if the presence of this pathogen is not confirmed by cultures. Discontinuation of the fluoroquinolone and especially the aminoglycoside should be considered after 3 to 5 days of treatment. The bactericidal activity of aminoglycosides and fluoroquinolones leads to a rapid reduction in the bacterial load during the first days of treatment. After this time, monotherapy may be sufficient. This approach would decrease the emergence of resistant mutants and minimize nephrotoxicity caused by aminoglycosides. The majority of infections can be effectively treated with 8 days or less of antimicrobial therapy. In a meta-analysis pooling data from 4 RCTs comparing short, that is for 7 to 8 days, with long, that is for 10 to 15 days, treatment periods, no difference in mortality was found. There was an increase in antibiotic-free days for the short-course treatment, and a trend to lower relapses in the long-course treatment was observed. Odds ratio equal to 1.67, with a 95% confidence interval of 0.99 to 2.83, with a p-value equal to 0.06. 4 situations may justify prolonged treatment, namely, 1. Infection by intracellular microorganisms, such as Legionella species. 2. The presence of biofilms or prosthetic devices. 3. Development of tissue necrosis, formation of abscesses, or infection within a closed cavity, such as empyema. And 4. The persistence of the original infection, such as perforation or endocarditis. If the clinical course from the pneumonia is favorable, as defined by defervescence, improvement in PaO2 to FiO2, and reduction in C-reactive protein, abbreviated as CRP, levels within the first 3 to 5 days of antimicrobial therapy, treatment may be withdrawn after 7 days. If the causative microorganism is a non-fermenting gram-negative bacillus, the treatment can be extended beyond 14 days. A large prospective, multi-center, randomized trial study comparing the efficacy of 8-day and 15-day antibiotic regimens for treating ventilator-associated pneumonia suggested that an 8-day regimen reduces antibiotic use and decreases the emergence of pulmonary multidrug-resistant bacteria, without modification of the prognosis. However, this study observed that in cases of pneumonia produced by non-fermenting gram-negative bacilli, eradication of these microorganisms from bronchial secretions was lower with the shorter regimen. On the other hand, the 14-day treatment regimen was associated with a trend to colonization by multidrug-resistant flora and a higher frequency of reinfection. Finally, in patients with clinical suspicion of ICU-acquired pneumonia who have a clinical pulmonary infection score lower than 6 on the 3rd day of treatment, antimicrobials may be withdrawn. In this setting, the patient likely does not have pneumonia, or the pneumonia is sufficiently mild such that prolonged antibiotic treatment is not required. Pause the video and carefully scrutinize Table 75-4 summarizing initial empirical antibiotic treatment for nosocomial and ventilator-associated pneumonia of late onset or in patients with risk factors for infection by multidrug-resistant pathogens and any degree of severity before advancing to the next slide. Pause the video and carefully scrutinize Table 75-4 summarizing initial empirical antibiotic treatment for nosocomial and ventilator-associated pneumonia of late onset or in patients with risk factors for infection by multidrug-resistant pathogens and any degree of severity before advancing to the next slide. Pause the video and carefully scrutinize Table 75-5 summarizing recommended initial intravenous antibiotic dosage for empirical treatment of patients with nosocomial and ventilator-associated pneumonia before advancing to the next slide. Pause the video and carefully scrutinize Figure 75-8 illustrating a suggested flowchart for the follow-up of patients with nosocomial pneumonia and ventilator-associated pneumonia before advancing to the next slide. We will now progress to treatment failure. At least 3 days of antibiotic treatment are necessary to achieve clinical improvement. Thus, treatment failure should be assessed between 3 and 5 days after the initiation of antibiotic therapy. The rate of treatment failure ranges between 30% and 50%, which highlights the severity and complexity of this pulmonary infection. In our previous observations, we developed a systematic definition of treatment failure comprising the following. 1. No improvement in PaO2 to FiO2, or need for intubation due to pneumonia. 2. Persistence of fever or hypothermia, together with purulent respiratory secretions. 3. Increase in the pulmonary infiltrates on chest radiograph of greater than or equal to 50%. Or 4. Occurrence of septic shock or multiple organ dysfunction syndrome. Thus, we found that no improvement in SOFA score and PaO2 to FiO2 highly predicted worse 28-day mortality. Importantly, treatment failure could be a surrogate endpoint for clinical trials to compare novel treatments. Upon evidence of treatment failure, respiratory samples should be reobtained and the initial empirical therapy rapidly readjusted. CT scan or lung ultrasound may help to detect cavitation, pleural effusion, and other causes for treatment failure. We will now discuss the implementation of therapeutic guidelines. Although guideline-recommended strategies may provide significant benefits for patients, implementation is often difficult to achieve. Su Hu and colleagues developed hospital protocols to manage patients with severe hospital-acquired pneumonia based on the 1996 ATS guidelines. After the guidelines were introduced into clinical settings, the authors found that adequate antibiotic therapy was administered in more than 81% of the patients with pneumonia, compared with 46% before implementation, with a p-value less than 0.01. Moreover, a lower mortality at 14 days was found after implementation of the guidelines, with a p-value equal to 0.03. Similarly, Ibrahim and co-workers developed a protocol to provide appropriate initial antibiotic treatment for patients with ventilator-associated pneumonia and encouraged a 7-day course of treatment. Thus, patients with ventilator-associated pneumonia, who were treated as directed by the protocol, more often received adequate antimicrobial treatment than those treated empirically, 94%, in comparison to 48% before implementation, with a p-value less than 0.001. The length of treatment was reduced by 6 days, and the second episode of ventilator-associated pneumonia was less likely to occur after implementation. And now in summary we will discuss few key points. 1. Nosocomial pneumonia is a common complication occurring in critically ill patients and is the leading cause of nosocomial infection-related death. Ventilator-associated pneumonia develops in tracheally intubated patients. 2. Etiologic agents for ventilator-associated pneumonia differ according to the population of ICU patients, duration of hospital stay, and prior antimicrobial therapy. Nosocomial pneumonia due to multi-drug-resistant pathogens is associated with the highest morbidity and mortality. 3. Preventive strategies, grouped as bundles, should be implemented in hospital settings. Several preventive strategies have shown efficacy in decreasing the incidence of pneumonia. In particular, the most effective strategies focus on reduction of cross-transmission, diminishing the likelihood of aspiration across the tracheal tube cuff, and decreasing bacterial load in the oropharynx. 4. In the presence of clinical suspicion of nosocomial pneumonia, diagnostic strategies should include an early collection of respiratory samples before starting or changing antibiotics. 5. The choice of empirical treatment should be based on the most likely etiologic microorganisms and the antimicrobials likely to be active against these microorganisms. Response to therapy should be reassessed after 3 to 5 days and antimicrobials adjusted or de-escalated to reduce the burden of the disease. Thank you.